So, a very good evening to all of you, and welcome to the session on to the neurology part of it, neurology NOEL. Before we start off the session, I'll just welcome our faculty for the day. We have with us Dr. Prakash Vemgil, who is a director as well as a senior neonatologist in Banarghatta, Bangalore branch, Rainbow Children's Hospital. We welcome you, sir, and thank you for agreeing to be the faculty of this. We have Dr. Pradeep Sharma with us, who is again a senior neonatologist from Deep Hospital, Ludhiana. Thank you, Dr. Pradeep, for joining us today and helping our students to have more clarifications in the presentation. We have our moderator, Dr. Arun Kumar, who is a senior consultant neonatologist from Rainbow Children's Hospital, Gindi, Chennai. And we have our presenter for the day, Dr. Latish Kumar, who is doing his NNF fellowship at Rainbow Children's Hospital in Chennai. So, over to you, Latish. You can go ahead and please start your presentation. So, we are live now. Please start your presentation.
Good evening, everyone. Today, I'm going to present a case regarding how a case regarding managing of HIV. So, the baby, coming to history of presentation, the baby was a single-term, 39-week term female baby with birth weight of 3.48 kilos, born to a primary gravida mother. And baby was delivered by vacuum-assisted vaginal delivery at a private hospital in view of shoulder dystocia and maternal exhaustion. The baby did not cry and had bradycardia, and baby had received the positive pressure ventilation. And later, baby was intubated and kept on mechanical ventilation and referred for further management at 4 hours of life. And coming into antenatal history, the mother was 28 years old, primary gravida.
Latish, just to interrupt you, can you please go to the slide mode because you are still, can you please go to the slide mode? Is it possible so that it's more better visible? Slideshow, please.
Yes, sir.
Yeah, that should be good. Please continue.
So the mother was 28 years old, primary gravida, non-consanguineous marriage, spontaneous conception, and it was a booked pregnancy at 11 weeks of gestation. Mother had regular antenatal checkups, and she had received folic acid in the first trimester, and in second trimester she had received iron calcium supplement and 2 doses of tetanus toxide as well. And there was no pre-pregnancy risk factors or maternal illness present in the mother. And mother's blood group was B positive, and all her antenatal scans done were normal. And other investigations like HIV, ELISA, hepatitis B, VDRL, all were negative. And perinatal events that happened, baby was delivered by vacuum assistance because of shoulder dystocia and maternal exhaustion. Baby did not cry after birth, and even on stimulation, baby did not cry, and heart rate was less than 100. So baby had received positive pressure ventilation, 4 cycles of positive pressure ventilation was given, and after that heart rate has improved. And after that baby was intubated in view of hypoventilation and gasping. And the Apgar score given at the outbound hospital was 2 and 4 at 1 and 5 minutes of life. And they have done a cord blood gas at the time, which was showing pH of 6.90 and PCO2 of 53 and bicarb of 12.2 with a base excess of 22.7, the severe metabolic acidosis. And when we have received the baby and examination during the admission. So the environment, baby was nursed under the radiant warmer, and baby was kept in air mode with 0 output, and thermometer temperature probe connected to the chest for surface temperature monitoring. And baby was intubated at the time of admission with 3.5 mm endotracheal tube fixed at 9 centimeter depth and connected to a ventilator. Is set on SIMV mode with pressures of a PIP of 16 and PEEP of 5 and rates were set at 35 per minute, and high time of 0.38 seconds with FiO2 at 30%. And the tubes were connected to humidifier, which was set at 37 degrees centigrade. And also, pulse oximeter probe was placed in the right upper limb, connected to a digital monitor for continuous heart rate monitoring as well as saturation monitoring. And left upper arm BP cuff with three size was placed for interval based BP monitoring with set alarms. And baby was placed with umbilical vein catheter, which was in place and was connected to two infusion pumps for IV fluid containing dextrose calcium, another one containing inotropes dobutamine. And NG tube was also in situ, which was fixed at 19 centimeters. And there was no aspiration, aspirates seen in the NG tube. And later, baby was connected to a critical machine with a rectal probe in situ and surface temperature probe connected on the forehead of the baby with core set temperature set at 33.5 degrees Celsius. And vitals at the time of admission, baby's temperature was 35.8 degrees Celsius and baby's heart rate was 130 per minute with a respiratory rate of 35 per minute on ventilator and capillary refilling time of 3 seconds. BP was 68 by 44 mmHg and MAP was 52, which was at 58 centile, and saturation behavior was 96% on 30% of FiO. And on general examination, baby's weight was 3.475, which was appropriate for gestational age, with head circumference of 35 centimeters, and length of the baby was 52 centimeters. And baby was having pallor with swelling over parietal and occipital region, with earlobes being displaced out. And baby was also observed to have periorbital edema, and with the right upper limb extended and externally rotated with no movement. And all the external orifices were intact. Genitalia were normal. And coming to systemic examination, respiratory system, baby was intubated, like I said, the 3.5 mm ET tube, which was fixed at 9 centimeter. Baby was on SMV mode with settings of PIP of 16 and PEEP of 5 centimeters. H2O rate of 35 and high time of 0.38 seconds with FiO2 of 30% and humidifier set at 37 degrees Celsius. On examination, chest was symmetrical and chest rise was adequate and bilateral air entry was equal and without any adventitious sounds on auscultation. And baby was maintaining saturation of 96% at right upper limb with an FiO2 of 30%. And central vascular system, baby had pallor and heart rate of the baby was 130 per minute and peripheries were cold. Bilateral central and peripheral pulses were regular and of normal volume. Capillary refilling time was 3 seconds. BP at right upper limb was 68 by 44 mmHg and MAP of 52, which was falling at 58 centimeters. And there was no visible pericardial pulses, and quality of the heart sounds was normal without any murmurs. Urine output was 1.5 ml per kg per hour in last 4 hours till admission. And baby was receiving dobutamine at 10 mics per kg per minute. And on abdomen findings, there was no distension, and UV catheter was in situ with no showcase of dressing, soft abdomen on palpation, and there was no organomegalism, and bowel sounds were present. So coming to central nervous system, on examination, skin was normal, and there was no nevi or any sinus or theft of hair was present. Head circumference of the baby was 35 centimeters, which was normal for age. And there was a diffuse fluctuant swelling present over the bilateral parieto-occipital region. And also there was displacement of the earlobes with periorbital edema. No facial dysmorphism was seen. And anterior fontanelle was bulging, but it was not tense, measuring at 3 into 3 centimeters. Posterior fontanelle could not be examined. And sutures were widened. And spine examination was normal. And on examination of behavior, baby's eyes were closed and irregular breathing was there. Minimal gross body movements and no cry or vocalization with a fetal state of 2. And habituation, baby was abnormal, and flashing light, he was not blinking the eyes. And cranial nerve examination, pupils were examined, which was 3 to 4 and it was reactive. And apart from that, could examine tone of the baby. Passive tone, mild flexion seen in lower limbs, and there was extension in upper limb. And on flapping of extremities to see for hypotonia, flapping was excessive, and there was marked hypotonia. And power, it was grade 1, visible, only palpable flickering contractions were present. And right upper limb, there was hypotonia, and upper limb was extended and externally rotated. So, and depending upon the clinical findings and suspecting HIE, so the tone of the baby was hypotonia, and consciousness, the baby was lethargic, and the seizures were present for the baby less than 3 per day, and twisting of limbs were there, and mores could not be elicited because and uh, grasp were absent, suck was absent, and fontanelles was full but not tense. Baby was having episodes of apnea on ventilator. So Thompson score was given at 14, and Levin's screening was also done, which was showing baby was lethargic with tone of hypotonia marked, and seizures were present, and baby was unable to suck. So it was falling under moderate HIV. So summary and diagnosis depending upon the clinical examination. Baby was term female, appropriate for gestational age, with moderate hypoxic ischemic encephalopathy with suspected subgaleal bleeding, and with a right side brachial plexus injury, anemia, and shock. Keeping that, and after that, initial investigations were done. So, blood group of the baby was AB negative, and hemoglobin is 10 gram percent. PCA was 30.7, and total counts of 33,720 per cubic mm. And platelets were 2.39 lakhs, and CRP was less than 5. And venous blood gas done at admission at 4.5 hours of life, pH was 7.35 with PCO2 of 35 and bicarb of 19.2 with base excess of 5.6. And other investigations at birth, 1.2 ionized calcium was there, and PT-APTT was 23 and 45, with sodium 138 and potassium 4.2 and chloride of 102, urea and creatinine of 21 and 0.06. And X-ray done had showed 7 to 8 space expansion with bilateral mild haziness, and ET was in position. So after that, management. So baby was falling under moderate HIE. So the temperature management and oxygenation, ventilation, circulatory management, hematocrit and metabolic milieu, and seizure treatment and nutrition. So all the management was done according to keeping that baby was moderate HIE. So therapeutic hypothermia was started for the baby, and with whole body cooling using critical machine with core temperature set at 33.5 degrees Celsius. Baby was started on IV fentanyl sedation, which was given at 4 mics per kg per hour. And baby was having a good vitals initially, and 10 hours of life, baby appeared to have myoclonic seizures, and baby was managed with IV phenobarbital with the loading dose of 20 milligram per kg. And after that, maintenance was started with 5 milligram per kg per day. And baby had complaints of shivering, and also had issues of bradycardia, hypotension on day 2 of life. So the set temperature was increased to 34.5 degrees Celsius, and inotropes were escalated at that time. And after 70 hours, sedation was tapered and rewarming was started with increasing set core temperature by zero point 0.5 degrees Celsius per hour till maybe 36.6 degrees Celsius, and warmer care was continued after that. And rewarming phase was uneventful. So at reassessment at the end of days 72 hours, Thompson score was evaluated at the end of therapeutic hypothermia, which was 5, and there was clinical improvement in the baby. So regarding the oxygenation and ventilation part, baby was continued on SIMV ventilation with the regular blood gas monitoring and maintaining a pH of 7.35 to 7.4 and a PCO2 of 35 to 40. Uh, Baby was extubated to CPAP at 72 hours of life with 21% FiO2 and 5 centimeter H2O of peak. And baby was stopped on CPAP by day 5 of life. He was on room air and was maintaining saturations at 95 to 96%. So coming to circulation, initially baby was started on inotropes, dovitamin, 10 mics per kg per minute in view of poor perfusion, and also along with IV fluids and empirical antibiotics with uh, piperacillin and tizobactam. And baby received a transfusion in view of worsening anemia. And on day 2, baby had complaints of bradycardia and also hypotension requiring noradrenaline infusion. And hypotension and bradycardia improved after the 6 hours of life. I mean, 6 hours of starting a noradrenaline infusion, and noradrenaline was tapered and stopped gradually over the next 6 hours. And baby was off inotropes by 72 hours of life, and antibiotics were also stopped. And seizure management, while baby was on therapeutic hypothermia, baby was having myoclonic jerks at 10 hours of life, which was treated with phenobarbital, 20 milligram per kg, and a maintenance dose of 5 milligram per kg per day. And cranial USG done showed midline large parietal subgaleal hematoma extending bilaterally. And EEG was also done on day 2 of life, which was abnormal. And day 2, baby had another episode of seizures, and it was treated with IV levetiracetam 20 milligram per kg and maintenance dose of 40 milligram per kg. And phenobarbital was stopped on day 5 of life as baby was seizure free from day 3, and oral levetiracetam was continued with 30 milligram per kg per day, sorry, 40 milligram per kg per day. And after that, MRI was done at 7 days of life, which showed a thin acute subdural hemorrhage in bilateral retrocerebellar fossa. And rest was normal. And brachial plexus injury was managed with initially the upper limb was immobilized at birth, and after that, X-ray was taken to see for any fracture, and X-ray showed no fracture. And on day 2 of life, limb movement was slightly present along the gravity, but there was no farmer grasp. So, pediatric neurologist and orthopedic and plastic surgeon opinion and consultation has been obtained, and they were advised for MRI screening of brachial plexus and advice for physiotherapy. And MRI screening on day 7 showed C8 preganglionic nerve root avulsion with pseudomeningocele was noted, and advice to continue physiotherapy and a regular follow has been advised. And slowly, by day 12 of life, limb movements have improved during the time of discharge and 12 days of life. So at the time of discharge, physiotherapy and follow-up was advised. So nutrition part, baby initially was kept nil by mouth on day 1, and later started on NG tube feeding on day 2 of life with 20 cc per kg per day, and slowly escalated to full feeds by day 4 of life. And baby was started on oromotor stimulation exercises, as well as Palade feeds started by day 5 of life, and breastfeeding was started by day 8 of life, and the baby was roomed in by day 10 and discharged by day 12 of life. So at the time of discharge, baby was hemodynamically stable, and baby was accepting a diet, just feeding and holiday feeds. And at the end of discharge, hemoglobin done last investigations before discharge showing a hemoglobin of 12 gram percent and thyroid functions of 2.73 mU per liter. So during discharge, Hammersmith neonatal neurological score was done, which showed a score of 31. So which was showing a score of 31 out of 34. Baby had improved, and a discharge advice was given to the mother regarding breastfeeding and physiotherapy and immunization as per schedule, and neurodevelopmental clinic follow and hearing assessment was advised with Vera at 6 weeks of age. That's all.
Very well presented, Dr. Am I
Thank you.
audible?
Yes, sir. Yes, sir. Yes.
Okay. So when you label it as hypoxic ischemic encephalopathy, what are the preconditions for that?
So preconditions.
Yes, yes. Or when do you label it as hypoxic ischemic encephalopathy? Because neonatal encephalopathy can have other causes also, but when do you call it as HIE?
Sir, when a baby is having a Apgar score of less than uh, uh, 5, and also baby was requiring more than positive pressure ventilation at more than 10 minutes of life, and when there is a cord pH of less than 7, and baby is having neurological symptoms like seizures and encephalopathy, and also having multi-organ dysfunctions.
Okay. And your blood gas was also correlating with that, with pH of 6.9 was there and base excess of -22, right?
Yes, yes, sir.
Okay. And sometimes there may be a sentinel event like antepartum hemorrhage, late fetal decelerations, etc. to correlate those findings.
Yes, sir.
Okay. So what are the other causes of encephalopathy in the newborn in the first week of life beyond perinatal asphyxia?
Sir, one could be maternal usage of uh, anesthesia during the birth,
Okay.
and any injuries, birth trauma,
Okay.
and uh,
Any metabolic disorders can mimic HI?
yes, sir. Metabolic disorders also in a well baby. Metabolic disorders can also.
Any examples? Any example that you can give?
Uh,
Suppose the mother gives a history of increased fetal movements and there are seizures with very early onset within the first 6 hours of age. What will you suspect? There are some other examples like molybdenum cofactor deficiency or sulfite oxidase
sulfide
deficiency.
oxidase dissipation.
Yeah, so they can be mimicker of HIE. So what are the other findings when you see the baby that you may suspect that is this is something beyond perinatal asphyxia? What else history you will take or the findings on the baby will you see?
Dysmorphism.
The
Very good.
patient,
One is any facial dysmorphism.
the baby was not having a facial dysmorphisms.
Okay, not in this case, but when will you suspect some neuromuscular disorder or something else in a case which may mimic HIE?
So one could be Piri Robinson sequence
Okay.
and floppy infant. The baby is floppy,
So generalized hypotonia may be there, but in HI also you may get hypotonia. So if the baby is looking otherwise alert, active, that you suspect something like SMA, etc. But here we are talking of neonatal encephalopathy. So okay, generalized hypotonia. What else?
And
Any dysmorphism you have said, microcephaly, for example.
yes, sir.
Okay. Suppose there is microcephaly, right? And there is some rash also. There is hepatosplenomegaly. You may suspect torch infections.
Torch infections.
But usually they do not present with severe encephalopathy so early. What else you will think of? Sometimes even strokes, arterial ischemic strokes may present with encephalopathy and focal seizures.
Yes, sir. Vena galen malformations could be another cause.
Yes. So anything else?
And sir, severe.
Suppose there is history of polyhydramnios, decreased fetal movements, undescended testes.
The
What is
congenital,
the, yeah?
sir, CH should be suspected in the babies. Congenital adrenal.
That means the baby is having some swallowing dysfunction and decreased fetal movement. So some neuromuscular disorder may be there. That may present with such findings of polyhydramnios, decreased fetal movements, undescended testes, you know, and sometimes a palate is also some high arched palate. So you may think of neuromuscular disorders.
Yes, sir.
I may request the other consultants also to please chip in.
Yeah, thanks, Latesh, and thanks, Pradeep, for going through all the probable causes. I'm Prakash here. I think you took the case quite well. I don't have any problem with that. I think Pradeep has gone through all the possible causes of what the encephalopathy could be. One thing is we do if you look at the incidence of HIE, related to the birth asphyxia per se is around 78% in most of the literature. So there's something around that, the other causes of HIE. So that has to be always kept in mind in terms of evaluating. Yet, of course, the clear history probably depicts to something which has happened during the instrumentation and the baby succumbed to asphyxia or a component of HIE.
Yes, sir.
So that is a thing which you would look. And of course, along with that, you probably have to think laterally too, as Pradeep has mentioned. And if there is dysmorphism, you also probably have to think of nowadays you can get the genetic testings for some of these syndromic things. So you need to probably keep a sample of blood before you transfuse. So that keep in mind. And of course, send the septic workup and always think that, okay, the history doesn't match. Probably you may have to look for infection as the cause and start the appropriate antibiotics. And also probably if the baby is stable enough to do a CSF analysis. This is what most of the centers does. And I think the rest is been probably covered. Just going with the case, Pradeep, is it okay if I take the case further?
Yeah, sure, sure, please.
Yeah, so I could see that the management from the referring center at 4 years, 4 hours of age, it was transferred to you. That the pH was 6.9 with a base deficit of around 22. Yes. And I think the next gas what you did was once the baby is in your hospital after 4 hours of age, right?
Yes, sir.
So in 8 hours time, the pH was almost corrected.
Yes, sir.
And the base deficit was only minus, I think 3.5 or something.
Yes, sir.
So do you,
5.8.
5.8, okay. So do you think that this acidosis has been corrected rapidly? And if so, do you think they have given some bicarb or you gave bicarb?
It's actually history.
Or the baby got corrected by itself?
Sir, regarding soda bicarb, the referring hospital did not mention giving soda bicarbs.
So you use the soda bicarb in your unit?
No, sir, we didn't. That was at during the time of admissions.
Admission, you gave bicarb, you said.
Yes, no, sir, we didn't give, sir. That
Okay.
pH
So
was at
neither
the
you
time
know
of
that it was given there, not here in your hospital, right?
yes, sir.
Okay, so if it is not been given, then it has corrected quite well. And, most of these severely asphyxiated babies take a longer time. And probably there was no other organ involvement here. And that may be one of the reasons why it has got better.
Yes, sir.
And second question of mine was, did you had an intra-arterial line for this baby?
No, sir, only umbilical venous catheter was only placed.
Is there any unit protocol that you don't place arterial line?
No, sir. Actually, the referring center already placed a umbilical venous catheter and referred.
Okay, you couldn't get any peripheral arterial line, or you didn't wanted to look into the umbilical lines. That's
Yes.
what.
Yes.
Okay. Because in that situation, when you're monitoring a hypovolemic shock, it's very difficult, and especially when you're cooling, to have a non-invasive blood pressure monitoring.
Yes.
And if you have an arterial line, probably you would have had a better blood pressure control monitoring. Because we don't rely on the blood pressure; we look into other factors too. And that is what I was thinking. Did the baby get vitamin K?
Yes, sir. At the time of birth, vitamin K was administered at the centers, at the place of birth.
And was there any derange coagulation profile?
No, sir. No, sir. During the admission, coagulation profile was normal, sir. Only
Okay.
baby was having a hemoglobin level of 10, sir. And PT and APTT was within the normal limits.
Okay. Was there any echocardiography done?
Yes, sir. Echo was done, sir. It was normal structure and function, sir. With only PFO was there. Sir.
Okay. And what is the rationale of starting dobutamine?
Sir, baby was having initially during resuscitation itself, a baby was having a low heart rate. So that's why it was started at the right after birth. And
So
we have
that's
continued.
at hospital.
Yes, sir. And we have continued it at the time of admission. Baby was having pool peripheries. So that's why it was started in view of poor perfusions.
Because there are a lot of studies which show that that is not the first line of drug unless
Yes.
until you document that there is some kind of myocardial contractility issue and you want to
Yes.
vasodilate. Most of the centers or the papers which have been published shows epinephrine as
Yes, yes. In view of suspected myocardial dysfunction and features suggestive of HI, dobutamine has been continued after coming years.
Okay. So Pradeep, you can take further.
Sure, sir. So very well discussion, Dr. Prakash. Now, Dr. Latish,
Yes, sir.
it's good that your unit had a cooling system, but there are many units in the country who don't have access to cooling. So at least what is the minimum you can do to prevent further brain damage if you do not have the cooling devices with you?
Sir, we can try to give the baby passive coolings if the facility is not being equipped with active therapeutic hypothermia cooling.
Okay.
So in that we can try to avoid the external sources of heating, like switching off the radiant warmer, but monitoring the temperature at the same time, and removing the extra clothes that are being put on the baby, and by avoiding the blankets. So that can be done, and
How
at
do
the
you
same time effectively monitoring the temperature every 15 to 30 minutes if possible.
how do you monitor the temperature? Like where do you put the probe?
Yes, sir. We'll put the probe on the chest.
Or you do just put it somewhere else like a rectal probe? Are you using that?
So for surface temperature, we'll put a on the chest for rectal monitoring to monitor the core temperature inside the rectum at 2 centimeters of depth.
Okay, because not all units can do the cooling because of the resources are limited, and also sometimes there are units who can't afford to do repeated tests for sepsis workup or blood products if there is bleeding, because there are complications related to cooling also.
Yes.
So in that case, at least you must prevent hyperthermia, because
Yes.
every 1 degree rise of temperature will cause further brain damage. So hyperthermia must be prevented at any cost. Okay.
Yes.
And uh, Dr. Prakash had talked of echo. So what specifically, in addition to look for any structural malformation, what specifically you will look for in case of hypoxic ischemic encephalopathy when you are doing an echocardiography in a baby having shock?
Sir, one thing to see is for left ventricular dysfunction.
Okay, ventricular function to decide if you need inotropic support, right?
Yes.
What else? You will
And
look for the IVC.
yes, sir. IVC for fluid status,
Okay.
and to rule out any other structural abnormalities like patent ductus arteriosus. And
Also, these babies are at an increased risk
PH.
of pulmonary hypertension. Yes.
Yes, PH.
So you will look for that also.
Yes.
Okay. Uh, you have talked of phenobarbital
Yes,
to
sir.
this baby, and levetiracetam was also given. And also there is a question in the chat box that which is the first line of drug? What will you comment on this?
The phenobarbital should be the first line of choice.
So when do you give another drug? Top up with other drug?
Sir, when we have reached the maximum limit of 40 milligram, and after that, if the baby is having refractory seizures which are not being controlled, so then add-on drug should be
Okay.
referred.
And how can you look for seizures that are not clinically manifest but EEG seizures are there?
Sir, we should take EEGs.
Okay, but bedside something that can be monitored for 24 hours round the clock?
Uh, so amplitude based
Okay.
EEG should be monitoring should
So,
be the best choice.
so when you are looking at amplitude EEG,
Yes.
what are the signs of poor outcome? Like what are the poor prognostic features on amplitude EEG?
Sir, if the baby is not showing any, the baseline is persistent, and if there are low amplitudes with less than 6, and yeah, and one more, not able to recollect, and
Sir.
brief periods of 10 seconds of brief activity followed by inactivities.
Okay. And anything sleep wake cycling, if it's there, it's good or bad?
So sleep wake cycle is good prognostic factors.
Yes. So if it's a continuous pattern or a discontinuous pattern, it's a better prognosis relatively. Burst suppression, if the number of bursts is more or less, which is good and which is bad?
Uh, Sorry, sir, I could not
I
understand.
mean, in the burst suppression pattern, more the number of bursts, suppose it's good or bad?
Good, sir. It is good, sir.
Yes, very good. Okay. The parents may ask you a question, Doctor, what will be the long-term outcome of this baby? So in addition to the amplitude EEG findings, what additional things will help you to uh, tell them that outcome will be good or bad?
Sir, one thing during the discharge, the baby is accepting the feeds well, and if the neurological examination part, like Hammersmith scoring is good, and also if they have done any MRI scan which was normal, and there was uh, no feeding issues, and there was no tone abnormalities. So then we can tell that the prediction will be good or
Is
not.
there is there any role of general body movements in predicting the long-term outcome?
General body movements during the initial phases.
At okay. Dr. Prakash may chip into this, which is a better to
Can
get.
I add one thing into it, Dr. Pradeep? I think very well done the discussion, both Dr. Pradeep and Dr. Prakash. One small thing here, Latish. So, as Dr. Pradeep has been asking you about long-term prognosis, so one of the problems which we have, so most of the discussions has happened, but a very common thing which we all go through is counseling these parents.
Yes,
So
ma'am.
about the good prognosis, moderately good or bad prognosis, or short-term outcomes and long-term outcomes. So where do you keep your baby here in terms of counseling of the parents per se, like when they met you on day one or maybe after 24 to 48 hours, or at the end of 72 hours, I would say is the best time once your cooling is over and you can assess some of the reflexes.
Yes.
So do you think your baby has got a good prognosis here? And if yes, what were the good prognostic markers? Tell me 1, 2, 3, 4.
Ma'am, one thing, the baby did not have any seizures after the day 3, ma'am.
Very good. So one
And
was no seizures, baby was completely seizure free at the end of 72 hours.
yes,
And
ma'am. And also the baby's tone has improved. The baby's
okay,
tone has improved, and at the starting of the admission, the baby's neurological scoring, Thompson score was 14, and after that, at the end of the therapeutic hypothermia, the score has come down to 5, and
okay,
the baby's consciousness and habituation has improved.
okay,
So, and after that, baby was also extubated early, and post-extubation, baby did not have any apnea or desaturation.
very good. Yes.
Respiration was regular, and eventually there was no shock also. And sepsis was also not there. So we have stopped antibiotics as well at the same time, and cultures were also negative. So the baby's tone improved, and we could start the baby on Paladay feeds by day 5. So all these things uh, had a good outcome.
So a very important thing to add to is your end organ damage.
Yes,
So
ma'am.
we did not have any significant end organ damage. If you see your renal parameters, your blood
Yes,
urea, creatinine, the electrolytes, the liver function test were all normal. So that's also
yes,
another. And to talk to the parents about what are the good prognostic markers at the end of 72 hours when you counsel them and reassure the parents.
yes, ma'am.
That's again a very important thing.
Yes, ma'am.
So, Dr. Prakash and Dr. Pradeep, if you are okay with the case, then can I move on to some questions which have been asked onto the chat box so that we can clarify the students?
Yeah,
Sure.
sure. Please go ahead. Yes.
Sure. So, one of the questions which has been asked is there any, maybe Latish can answer this question. Is there any ABG criteria, Latish, for starting therapeutic hypothermia?
Yes, ma'am. If the pH of the baby is less than 7, and also if the base excess is more than 16, so that would be a criteria to start therapeutic hypothermia.
Okay.
So that was a blood gas analysis, ma'am.
Yeah, the blood gas analysis.
So other criteria, like if the baby is still needing positive pressure ventilation at 10 minutes of life, then that would be another criteria. And baby's Apgar score is less than 5 at 10 minutes of life. So that is another criteria. And if the baby's weight is more than 1800 grams, which was in this case, so that was another thing which was fulfilling the therapeutic hypothermia. And also the baby was a term baby, so more than 34 weeks. That
So
was
how
another.
many of these criteria you take, Latish, into consideration when you consider therapeutic? Not all, right? So one of them, two of them, including anything else which is the criteria to consider therapeutic hypothermia?
Yes, ma'am. If, at least more than 3. Ma'am.
Okay.
So if the baby is having a very severe metabolic acidosis, as well as a needing for the PPV more than 10 10 minutes.
Any single criteria which is very important to consider therapeutic hypothermia? One single criteria which can be there, which is important to consider therapeutic hypothermia for the term babies? That yes, baby would need, apart from the ABG criteria and whatever you are talking about ventilation, one single important criteria.
There should not be any life-threatening features.
Neonatal encephalopathic features. So if the baby is encephalopathic with seizures happening,
Seizures, ma'am.
yeah. So that's important. So what is the second question is, what is the ideal loading dose of Levera?
Ma'am, initial loading dose is 20 milligram per kg per 20 milligram per kg.
And then you can go up to how much dose, maximum dose?
Maximum of 40 milligram per kg.
And how many times you can repeat the dose? Like you have given 20 mg, you have given 40, you give half loading dose?
Yes, ma'am. We can go a maximum of 40 only.
As Dr. Pradeep was asking you, when do you switch over to phenobarbital or the second anti-epileptic drug according to your unit protocol?
Ma'am, after reaching the maximum of 40 milligram, and then after that,
You go
we'll
to the
start.
second anti-epileptic drug.
Yes, ma'am.
So similar to this question, maybe Dr. Pradeep can answer this question. Is Levera a preferred drug over phenobarbital as the first line agent considering the sedation?
The advantage of Levera is, of course, less sedative and maybe having less apoptotic effects. But if you compare phenobarbital and Levera, most of the literature that is available is either Levera is inferior or it's not superior to phenobarbital. So still for most of the units, phenobarbital remains the first line of drug, especially for dyslexia. And most of the units go to either phosphoenitoin or Levera as the second line of drug. But remember, if there are early seizures, very early onset of seizures, one may also consider adding pyridoxine also for that in case of early seizures. Yes.
Okay. Thank you, Dr. Pradeep. So next question is, maybe Dr. Prakash can answer this. If pH is less than 7 and the base deficit is more than 12, would you like to give soda bicarb or not? So I think that question goes to Dr. Prakash because
Yeah.
sir was asking about this.
Yeah. So, if you look at the pH, if it is less than 7, and then look at the bicarbonate, probably when you finish, probably I would I wouldn't jump and give bicarb. Probably I'll see what has to be done. And usually probably it's volume replacement, cardiovascular support, and respiratory support is what you need to do. And then obviously if the acidosis persists or the pH is still low, less than 7, and the base deficit is going up, then you probably can think of giving a correction, probably a half correction for the next 4 to 6 hours. That's what generally our unit follows. But I don't think so we should jump into that. We need to find out what is the cause for this acidosis. So stabilize this baby, get everything sorted out, and then look for other things.
Agree. I think yes, fair enough. So
in our case here, the hemoglobin has dropped to 10, and that probably is the reason why the acidosis was there, and the baby had bled subgaleal, and hypovolemic shock was probably the cause for the initial insult. And if you don't correct that, and either by volume replacement and try to give just the bicarb, you might not have a good outcomes.
right.
Yeah. If I may add a little thing, like this baby, Dr. Arun here, this baby was in the referral hospital, was on CPAP. When the first blood gas was done, baby was on CPAP. So
intubated.
after that, we was intubated. Once the baby during the transfer, the first gas itself was improved. Thus, giving the respiratory support itself, when adequate fluid resuscitation, inotropes, itself improved the blood gases for this baby.
Yeah, that is what is probably.
So the next question is maybe Latish can answer these questions. One of the questions which is there, what is the classification of mild, moderate, and severe asphyxia based on ABG? Is any such classification exist?
Based on ABG?
Yes. Maybe I also don't know. Maybe Dr. Prakash and Dr. Pradeep can
No,
also.
it is not there. We have only basically 3 scores. Satnath doesn't mention about blood gas. Even Thompson doesn't have any living.
Doesn't have any such,
So the only difference between Sarnath and Thompson is Sarnath has more of mild, moderate, and severe. Thompson is more of scoring the system. So like the score of 0 to 4 or 5 or 14 or anything more than 14 is what the score, the severity is.
Right. Another question, maybe Dr. Pradeep can answer about MRI, sir. So what is the indication of MRI, when it is indicated, when it should be done? And yeah, so what is the indication of MRI and when it should be considered in a baby with HI?
Plus minus 10 to
Can Dr. Vedant switch off your mute yourself? Dr. Vedant, can you mute yourself, please?
So as MRI is concerned,
Yeah, please, Dr.
of
Pradeep.
baby are
Your
on
voice is
therapeutic-
not clear. I think your network is a little disturbance, sir.
Okay. Switch off the camera. The
Yeah.
MRI, when we talk of the MRI, because these babies are on therapeutic hypothermia for the first 72 hours, and also accept the diffusion weighted changes, we will not be able to find much findings. So preferably the MRI is done usually after day 4, and you can do it till day 14, because after that pseudo normalization occur and you may miss the findings. So this is the time when MRI can be done, and earlier it can show the diffusion weighted changes. But as far as the indication is concerned, all babies who had encephalopathy, because MRI will be able to do the prognostication also, but make sure the baby is stable hemodynamically before you shift for the MRI, because the baby may become deteriorated in the transport itself. So stabilization is more important, because the immediate treatment is not going to change with the MRI findings most of the times. Also, if you are suspecting other causes beyond perinatal asphyxia causing encephalopathy, like non-asphyxial causes, then also MRI will be one of the indications.
Right.
I'll
So-
just add one more thing for MRI. When you do an MRI, kindly ask for MRS also, the spectroscopy, to measure the lactate and N-acetyl aspartate levels, spikes. And that will probably, it's most of the important prognostication, especially the neurologists would prefer to have. So anyhow, the child has gone for MRI, get MRS also along with that.
So Latish, a question to you.
Yes.
When is any one indication when an MRI, as Dr. Pradeep has told, that it should be posted a little later, maybe day 4 to 14 ke beech mein, is there any indication where an early MRI is recommended? Where you prefer, which helps you in even deciding about the continuation or discontinuation of the treatment or something like that? Is there any such indication where you or neurologists prefer you to do an early MRI within 72 hours?
If the baby is having persistent seizures and abnormal amplitude EEG,
Okay.
so, then it's preferred to go for early MRI.
Okay. So
And
any
suspecting
associated bleeds in the brain? Is it a
yes, and
possibility when you have got a
suspecting any intracranial hemorrhages.
cranial hemorrhages? Can always have an impending indication to do it early, along with the grade 3 or severe HI, where we are having recurrent seizures not getting controlled.
And also, if you have any major congenital malformations of the brain where the prognostication is going to be poor, like lysencephaly, holoprosencephaly, and all those ones.
Right, right. So I think the questions from my side are done. I think the students have this much is the question. So maybe any important take-home messages, Dr. Prakash, from your side for the students to understand it better?
Well, I think most of the students in the examination probably will be asked about some of the studies which have been extrapolated, which has been practiced. So they should know about some of the studies which have been based on that. All these treatment options are there. The NIC DHT trial, TOBI trial, ICE trial, CoolCap trial, and also the latest Helix trial, the controversies or non-controversies associated with that. what does it mean? These are some of those studies. They should know at least the basic part of it and try to, replicate when they are asked in the examinations. And also there are a lot of papers which have been looked for preterm babies, whether they can cool IUGR babies, mild encephalopathy, whether we should cool more than 6 hours if they receive the baby, how long we can cool. So there are no clear-cut evidence or guidelines for that. I think the students should know that all these trials have been done in small centers, and the numbers are very less, and there's no good data to support that.
Dr. Prakash, one of the students have requested you to please repeat the name of the trials which you have quoted.
So it is called NICHD trial. It is a meta-analysis done in 2012, if I'm right, and the same meta-analysis was done in 2013. The outcomes were the same. These are the 7 RCT trials which they looked into the newborns, and based on that study is what the recommendation is. The number needed to treat an infant by cooling is, if you treat 7 children can have a better outcome versus no. And there's other trial called Toby trial, ICE trial, ICE trial, and Cool Cap and other 2 trials are only selective cooling of the head. Yeah. So that is, and the latest 2022 or 23, I think, is the Helix trial, which came published in the lower resource source country, which was probably, they kind of published saying that it's a negative trial compared to the others, but there are some issues and people do debate on either side, and I leave it to the audience to take it which side they want to debate on that. So there are some other research which is going. They used it more of erythropoietin usage in some of the trials, but that has not been extensively used. And they also use some biomarkers to measure. And again, it is an experimental tool. In some babies, the biomarkers are elevated and the prognostication can be bad. So these are the things which they can probably read in the books or in some of the review articles which have been mentioned, just to complete the whole scenario of HIV.
Sure. Dr. Pradeep, over to you, and take-home messages from your side to the students.
In babies with perinatal asphyxia, hypoxic ischemic encephalopathy, supportive care is of utmost importance. So whenever there are seizures, always recheck blood sugar, ionized calcium, and other electrolytes like sodium, because the long-term outcome also depends on how well the seizures are controlled. Also, these babies are prone to sepsis. So asepsis and close monitoring of sepsis with doing the markers. The only thing is the sepsis markers like CRP, TLC, IL-6 also change with asphyxia. So it sometimes becomes very difficult to differentiate the two. So send repeated cultures also. Also make sure the antibiotic dosages are readjusted, because these babies have renal dysfunction and hepatic dysfunction also. So let them not land up in renal failure just because of the antibiotic dosages also. So these are the things I would like to add.
Okay. So to add to what Dr. Pradeep has told also about the feeding protocol, a lot of students have this thing, can we feed the baby while we are cooling the baby or rewarming phase? And I think in your case also, you have started the feeding
Yes.
after 24 hours. So you did not give the feeding for first 24 hours. So
Yes,
there
ma'am.
is no such contraindication for feeding when you are doing a therapeutic cooling unless there are like quite a lot of inotropic requirements, significant hemodynamic instability,
Yes, ma'am.
just therapeutic hypothermia. There is no such contraindication to start. Please go ahead and give minimal enteral nutrition, 20 to 30 ml per kilo, and you can even go up onto the feeds. Continue to maintain minimal enteral nutrition even during the rewarming phase. There is
Yes,
no such contraindication to stop the feed or hold the feeds.
yes, ma'am.
Okay. So, Dr. Arun, anything from your side, Dr. Arun? Do you want to
Yeah, I
comment
think
anything or any take-home messages for the students on your behalf?
main thing is already Dr. Pradeep has mentioned about the supportive care. Supportive care here, what are the targets we should have, like for the ventilation, for the inotropes, for the sugar? Should have a clear targets in that. So what is the target? Latish, can you tell about these things? The CO2 target, this one, these babies. Whether to go for low.
The CO2 target should be maintained from the 35 to 45, sir. And
Yeah,
PC
usually here it is normalizing the target. It's normal, around near normal, not hyperventilation. Neither it should go for acidosis.
yes,
Too
sir.
much hyperventilation also can result in the problems. And
Preventing
then
hypo.
maintaining the blood pressure and a good urine output. End organ damage, which is the one we should always try to prevent. So maintain a good urine output and perfusion and blood pressure monitoring. If these things will carry a long way in treating this baby, rather than cooling is only one part. The major part is the supportive care, especially the ventilation, sugar management, IV fluids, not too much, and too much restriction also should not be there to these babies. And of course, as Dr. Nita said about feeding, there is no contraindication to stopping the feeding in these babies until unless you have a severe hypotension requiring vasopressin for a long time, and also severe acidosis.
Thank you, Arun. So I think Dr. Prakash, Dr. Pradeep, thank you so much for joining us today and being the faculty of this session. And thank you, Dr. Arun, for preparing Latish well. He has done a very good presentation. And I think if every student presents like this during the exam, examiners will really think about what to ask and what not to ask. So
That's
thank
a
you,
good
everyone.
good job, Latish.
Thank you so much. Thank you,
Very
ma'am.
Thank you, everyone.
Thank you very much,
Thank you,
Natasha.
sir.
Thank you, sir.
very much.
Thank you so much.
Thank you, Pradeep, and thank you, Arun. See you.
Thank
Good
you,
night.
sir. Good.
Thank you, sir. Thank you so much.
Thank you, sir. Thank you, sir. Have a good night, sir.
Thank you.
Thank you, Prakash.
Thank you, Arun, sir. Good night, sir.
Right, Latish.